Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristen Jackson. Every week, I share my over 25 years experience to guide both men and women as they age. Listen as I discuss a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. It's happening to all of us, so listen for some solid scientific knowledge on how to handle these changes. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. Well, welcome back, everyone, to the podcast. We are really blessed today to have Dr. Sarah Cigna with us. She is a sexual wellness and health expert, and we're excited to pick her brain about what she knows about sexual health. So welcome.
Thank you so much for having me. I'm excited to be here.
Of course. Tell us a little bit about your background and how you became interested in sexual wellness.
Well, I started really as a med student. I was at the George Washington University, which is where I still work now. And in my fourth year of medical school, I did a elective rotation with Dr. Andrew Goldstein, who's one of the pioneers in treating and diagnosing sexual pain disorders. And just had this whole world opened up to me that I didn't know existed. And couldn't believe I really hadn't heard much about the vestibule during my rotations, didn't know much about vulvar anatomy or the hormonal involvement of different parts of the vulva in pain disorders, and just wanted to learn more. So I kept going back. And as a generous mentor does, he kept inviting me back, and I did a lot of shadowing all through residency. I stayed at GW for my OBGYN residency, and then after graduation was able to negotiate a part-time gig with him so that I could get that close apprenticeship over the course of 2 years. So I call that kind of my fellowship. It's a time that I spent with a lot of feedback from him, a lot of mentorship in research and my clinical skills, my surgical skills, and then was able to open up a clinic that was insurance-based at the George Washington University, which was really exciting and really my mission.
That is so great. And I think that really points out something that's important. Even in routine OBGYN training, your regular OB down the street who you see every year for your GYN exam probably doesn't have this breadth of experience with sexual wellness issues and sexual pain disorders because it's not necessarily prioritized during training. Do you agree with that?
Yeah, absolutely. I think that when you look at the objectives, which are the CREOG objectives for OBGYN doctors when they're going through training, you see that there are sexual health topics that are outlined in these objectives. However, there isn't the same training that comes from a lot of the leadership in CREOG to kind of pass down and actually make it a practical and very hands-on experience. So you might be hearing some theoretical things, and some of it may not be correct because we know that the evidence is really lacking in women's sexual health. And so there's a lot of practices that are based on myths. So we have to be really, really careful about what recommendations we make, what treatments we're using, making sure we're really basing our recommendations on evidence. And that's something that's been lacking in OBGYN training in addition to the rest of society. So it's not just an OBGYN problem, it's really a society-wide problem that we have to address. And we're just trying to get at it, one learner at a time.
I agree. I think even in my training, I think we were trained to investigate and ask patients about sexual pain and health issues. But when the patient said, yes, I am having these problems, then it kind of ended. Well, what do we do about it? So now I've asked about it, but I don't have great recommendations for you. So I think in real life practice, that makes OBGYNs fearful to ask because we don't like to uncover problems that we can't help the patient with.
Exactly. It definitely creates a barrier between providers and their patients. I think one thing that's really interesting to note is that many sexual pain and sexual dysfunction disorders were thought of as psychiatric disorders. So everything was thought to be in that person's head, not something that needed to be treated medically, but rather something that would be treated by a sex therapist. And for those listening, a sex therapist is not someone who watches you have sex. That That's one thing my patients are always like, sex therapy, like, I don't want to have
Right.
sex in front of somebody. What happens? So it's a trained psychologist or psychiatrist or a sex counselor who knows so much about communication. So much of it is about communication and about reframing different biases that we have that we grew up with, different barriers that we find mentally around, history of trauma, history of shame or guilt associated with sexual activity. And these things, it does take some mental work to get around, but a lot of the medical disorders are really things you can treat with hormones or nerve medications, muscular treatments. There's a lot out there for people, but you have to be able to parse out the different pieces of it. So we talk about the biopsychosocial model in sexual medicine. And really what that means is that we're not only looking at the biologic and physiologic causes, we're also thinking about the mental health of that person, and then also their social context. So who their partners are, and what their support system is like. So it's a big picture treatment.
It definitely is. So let's get into that. What are some of the top concerns you see from sexual health for patients coming to your clinic?
So in our clinic at GW, we have the Saga Center, the Sexual Health and Gender Affirmation Center. And we see the majority of our visits are for pain. It's just so common. 1 in 4 people will have some kind of vulvovaginal pain that goes on for longer than 3 months, which designates it as a chronic genital pelvic pain disorder. So vulvodynia, vestibulodynia are some of the words that people might hear. Vaginismus is another common one that's used. But 1 in 4 people with vulvas and vaginas will experience this. So it's so common. And there aren't enough people that know how to do a very systematic exam, history, and then offer treatments that are evidence-based and not, just relax or have a glass of wine, right? Those are not evidence-based.
Right.
They're very effective treatments. Many of them involve a pelvic floor physical therapist. But that's the most common thing that we see. I'd say the second most common would probably be vulvar derm disorders. So we see a lot of lichen sclerosis, lichen planus. These conditions are very inflammatory and they can cause a lot of vulvar itching that doesn't get better with hormones, itching that doesn't get better with steroids necessarily, itching that just keeps persisting. And sometimes there are other types of medications that we need in order to sort of manipulate the immune system in the skin there, that's unique to the vulva. And so we see a lot of that. We do vulvoscopy, which is where we look very carefully at the skin, and we offer treatments with other specialties that help us really provide a multidisciplinary care plan for that patient. The third most common thing we see, I would say, is probably orgasm disorders. And orgasm disorders are really common. I would say they come along with pain a lot of the time. So 2 reasons for that. First of all, people who have a lot of genital pelvic pain, a lot of it has to do with their pelvic floor muscles being often too tight. And when the muscles are in spasm like that, they're not able to generate a good contraction, because they're already contracted all the time. And when that happens, people often say that their orgasm is very muted, or it's kind of subdued from what it was before. And so people often think, oh, it must be my clitoris. There's something wrong with my clitoris. But actually, the clitoris is what transmits the signal, right, to the brain to say something's touching and it feels good and it's pleasurable. But the muscles in the pelvic floor are a lot of what provides that pleasurable sensation of rhythmic contractions during orgasm or climax. The other reason we see a lot of orgasm dysfunction in pain patients is related to the fact that if you have pain, it's really hard to ignore the pain and experience enough pleasure to have an orgasm. So many of our pain patients also suffer from anorgasmia, or the difficulty of having an orgasm at all. And that varies. There's different treatments, but oftentimes we have to address the pain first. That's kind of the main thing that we look at. But those are the 3 most common things that we see, and we see a lot of it every day.
Absolutely. I think so much of it comes back to pain, as you described how common it is, and pain from a whole variety of sources, right? Maybe it's pain from those tight pelvic floor muscles. Maybe it's pain from a dermatological condition around the opening of the vagina. And once that pain has set in, like you said, it becomes a cycle in the patient's brain. So even before there's any kind of sexual contact, they're now fearful of that impending sexual contact. And what fear does is make our muscles contract even more. So that worsens the problem. And we really get into this bad cycle. We talk to patients a lot about trying to break that fear and pain cycle. And the only way to do it is treat the pain and make sex less painful and pain free.
Yeah, one of my favorite visits to do in the office is for patients who I've performed a vestibulectomy for. In around 6 weeks, they come in for a particular post-op visit where most of the stitches have healed. Their swelling is down. They're able to move around much more easily. They're much more comfortable, and we're able to redo their Q-tip exam, which is where we check the vestibule for those pain spots. And when we do that and then we put in dilators and things don't hurt nearly like they did before the procedure, that aha moment, that mental click of the light bulb going off, like, oh, it doesn't have to be painful, is really important for breaking that cycle. Because, like you said, you can treat even the superficial pain, but as long as you have that fear of pain, fear of impending pain, you're going to be contracting those pelvic floor muscles. So there's a lot of mental work that happens in that.
Yeah, that is a great moment when women realize something can go inside and I'm okay with it.
Yes,
And
exactly.
it feels fine. Like at least they can move from painful sexual intercourse to painless. And then the next step, of course, is pleasurable sexual intercourse.
Yeah, I love seeing patients when they come in after getting so much improvement in their pain. You can tell. I know you probably see this too. You see them walk in, they look lighter, they're smiling immediately. You walk into the room and they're like ready to talk to you and share. And you can just tell all around, like, I already knew you were better just by looking at how you were walking because
That's
it
right.
affects your entire quality of life. People are genuinely happier when they're not in pain.
Of course. And I think, in our practice, we see younger women with pain issues, but then we see women in the perimenopausal or menopausal change. And a lot of them have been having successful intercourse their entire lives, but now they've gone through menopause and they're in this whole area of life that no one prepared them for. So let's talk about how menopause negatively affects sexual health and how patients can improve it.
Menopause is a really big transition. And I think one of the most challenging pieces of it is that because we haven't really routinely been educating people proactively about it in the office, they're not expecting it when it comes. And so folks come in their mid 40s and they're already noticing some changes. And it's a little alarming to them. They're like, I knew my body for this many decades. It was one way all the time. I had my period this many days apart. And all of a sudden, everything gets turned upside down. And that results in a lot of mistrust in people's own bodies, which sets the stage for what can be a really challenging transition when the periods actually do stop, when people go into that postmenopausal phase after not having a period for 12 months. And then you have a big drop in the hormones, including estrogen, progesterone, testosterone, and these are really important for sexual function. So causing things like vaginal dryness, causing things like decreased desire, decreased arousal, inability to have an orgasm, orgasms changing in character. It's all related to these big transitions in the hormones, and we should be treating it and thinking about it proactively to help people make that transition so much less traumatic.
I agree. It's the most frustrating thing I hear. And unfortunately, I just hear it from patient after patient is they talk to one of their physicians about it. And the physician told them, well, that's what happens when you get older. Things are changing. You're just getting older. And that's not the right answer at all. I mean, yes, you are getting older. And yes, things are changing. But no, you do not have to be accepting of it. And there are so many options to improve the quality of your orgasm and the pain and the dryness and the lubrication. So it's just so frustrating that women have often been through more than one physician who's told them that's what you can expect as you get older.
Yeah, I think that as clinicians, it is not our job to judge how bad something is for a patient, I think that can be one of the most damaging things that we can do for the relationship that we have with our patients. We should be legitimizing their concerns, and even if there's not something direct that we can do because there's not a treatment for every single symptom of the menopause transition, but there are many tools, including lifestyle things, that we can do to help mitigate those changes and make them less uncomfortable for people. And if we're not offering those things to every single person who walks in the door with those concerns, we're really not giving equitable care.
Oh, that's such a great statement to make. I agree, especially things like atrophic changes where the vagina gets dry and less lubricated. I truly believe, I mean, after seeing 10,000 people, women feel those symptoms before clinicians can see physical changes in the vagina. So very often the physician is looking and saying, well, everything looks fine to me, but the patient says, but it feels dry during intercourse. It feels like knives. It feels like razors. It just feels like he's tearing me up inside. Those are true concerns. That is truly how she's feeling. And she's noticing those changes before we're seeing anatomical changes on the physical exam, and they deserve treatment.
Absolutely. And in the same vein, we were talking about the different layers of pain, right? And all of these sexual health concerns. And some of those layers are that hormones are a part of it. And then there's another part, right? Because once you have painful sex, then the next time you're anticipating the pain, now the muscles are starting to get tighter. And it leads to this kind of domino effect of suddenly now you have multiple layers because we haven't treated the problem early and quickly, right? We could have avoided the muscles tightening up and getting into spasm if we had just treated the hormonal issue from the very beginning. Particularly for, I think, like that 42-year-old who comes in and says things are just a little more dry, like I don't get as lubricated as I used to. And we have to listen to those little cues so that we can prevent these things from getting to the catastrophic stage where people are having trouble maintaining their relationships, and with themselves and also with partners. And, there's talk about divorce and infidelity, and it's just devastating. And it's all preventable, really.
It is. And then the other side of that, I think, is in that perimenopausal transition and menopause time when women feel the loss of libido and sex drive. And I just very commonly hear, it's not that I'm not attracted to my husband or I don't love him anymore. I could rather fall asleep rather than have sex. And if I do decide to have sex, I end up enjoying it. But to try to get over that mental hump of I actually want to be sexually active is so difficult. So if you don't attend to that early and help them, unfortunately, we know when couples go through really long time frames of just less and less sexual activity, besides all the relationship problems it occurs, it's much harder then to get back into sexual activity after 5 or 10 years versus just a few weeks or months.
Yes, definitely. You get into those patterns and it's really, really hard to break.
Mm-hmm.
The other thing about menopause transition that I find to be really challenging is all of the outside influences on sort of the decision to start hormones or the decision to consider an off-label medication, even if there are evidence and studies behind it showing its efficacy in postmenopausal people. Many medications have to be FDA approved in certain populations first before it can be broadened to larger populations. That's just how the FDA approval process tends to work. Flibanserin, also known as Addyi, is a medication for low desire. Now, it's FDA approved for premenopausal patients or people who are still having periods who have low desire with no other known cause. But if someone is postmenopausal, there's actually studies showing that it is effective for postmenopausal people as well, especially those who might not be a candidate for hormones. And so we shouldn't be withholding these things just because there's one piece of the picture that says that they can't have it or they wouldn't benefit. We always have to look at all of the evidence. Another example would be hormones and risk of breast cancer, because it's a huge topic right now.
Yes.
So local vaginal hormones do not cause breast cancer, period, end of story.
Yes. Can we please stop talking about that
Yeah,
in all
right.
patient populations?
Exactly. And then systemic hormones, it's a conversation because there are risks and benefits to different types of hormones, different mode of delivery, whether it's an oral pill or a patch. But there's all of these blanket statements that are made about various medications to do with women's sexual health. And it really creates barriers because clinicians then don't feel comfortable because they're not sure if they're doing something safe. And it's based on wrong information, which is very frustrating as someone who treats this every day.
Oh, I know. I could not agree more. I mean, the number of people who have been told to shy away from local vaginal estrogen, just, well, you're at a certain age, you shouldn't use it anymore, or your grandmother had breast cancer, you shouldn't use it at all. All of those are incorrect statements. And I'm not placing blame anywhere. It is lack of knowledge, but then the patient gets that in their head. Well, my primary told me I shouldn't use it. And that is the hardest thing to break for women, even when you're describing to them, is so much data to support the safety of this medication lifelong. It's really hard to break that initial statement that they got in their head that they shouldn't use it. And they feel like they're doing something wrong. Like, well, I'm going to try this vaginal estrogen, but I really shouldn't be using it. And I don't want them to feel that way. I want them to actively use it and know that it's good for their health.
Yeah, I think, patients will come in for their annual exam and, they're there we're talking about bone health, we're talking about exercise, we're talking about all this stuff. And then they bring up the menopause, like, because I ask every patient, are you experiencing any perimenopausal or menopausal symptoms? And they'll say, yeah, but, I don't know if I need to do anything about it. And, my mom had breast cancer and when she was older and, this conversation sort of evolves into them already depriving themselves of even the opportunity to talk about it. So I say, well, let's have you come back. And then we do a half an hour just talking about menopause. We talk about the Women's Health Initiative study. We talk about the history of hormones. We talk about hormones now versus then. We talk about risks of the different formulations and figure out a plan that would actually make sense for them. That way, when it does come time that they feel that they want to start something, we already have a plan in place that makes sense for their individual health history. So I find that to be a really powerful tool. But again, it's a lot of breaking down myths and incorrect information that they've learned elsewhere.
Exactly. We do that exactly the same in our practice. We do a 30-minute consultation, fully educational. Let's just talk about your symptoms and your personal family history. But a lot of the education we give them is applicable to every single patient, like all the background on hormones and the different routes and the risks with oral versus transdermal and things like that. And patients almost to a T are just shocked to learn it all. And I had no idea. And even if they don't choose to begin any therapy at the end of that visit, that's at least one more educated patient, hopefully going out into the world.
Absolutely. Yeah,
Yeah,
I think the resources that we have available online are so mixed. And so it's really hard, I think, for patients to even educate themselves independently because what's out there on Google is really variable too.
exactly. So obviously, you have such a great clinic where all of these issues can be discussed and properly evaluated, and that takes training and time and energy. How can patients advocate for themselves when they're at their regular GYN doc or their primary care and they're having some of these issues, but they feel like they're just not getting the attention from their physician that it really should have?
For patients who have access to see somebody who is a menopause certified practitioner or someone who's affiliated with an institution like ISWISH, which is the International Society for the Study of Women's Sexual Health, which I'm very involved in, you can feel pretty sure that that provider, that clinician is going to be able to provide you very evidence-based recommendations about things like hormones and menopause treatments. If you don't have access to one of those people, which is a reality for a lot of people, then I would say looking online at some of these websites. So NAMS is the North American Menopause Society, and then ISWISH, which I just defined earlier. ISWISH has a patient-facing website called Procela. .com, and it's a great resource for really good information that they can then actually print out and take to their doctor. Because sometimes when doctors see that there's actually an international or national society that is stating something in black and white on a piece of paper, they realize like, oh, maybe I need to learn a little bit more about this because clearly some things have changed since I was trained. Because a lot of us were trained in a time when the Women's Health Initiative was the law of the land. And we have to remember that, things change, data's reanalyzed, and we realize new truths. But not all of that information always trickles out or gives people the empowerment to practice differently because they're afraid of hurting people. I think that, it does come from good intentions. Clinicians are not trying to deprive people of care. They're just trying to be safe and they don't want to do something that could harm a patient. But we have to arm them with the information, and patients can do that by bringing them articles that they see on these nationally and internationally recognized sites. So I think that's actually the most powerful thing. Patients bring me stuff all the time. I get articles every day about a new treatment. I learned about a new yeast infection treatment from a patient that way. And I mean, I so appreciate when patients bring in this kind of information because it does help us all get better care.
Oh, I agree. And I will link all of those institutions that you referenced in the podcast description. So if any listeners want to look into them, they can click on them right there. But that is great information. And I agree. No physician wants to harm their patient or cause a negative outcome for their patient. And I mean, I'm a urogynecologic surgeon, so I'm constantly providing my patients informed consent before a surgery or a procedure. So you need to know the risks and benefits of your procedure. But with hormones, I very often talk to patients about negative informed consent. Here are the risks and benefits of starting a hormone replacement therapy, but here is what you can face if you choose not to. Here are the symptoms you can expect to feel, and here are the long-term health risks you are going to face by being deprived from your hormones for 20, 30, 40, 50 years. And I think that negative informed consent is something that doesn't get done enough for patients to understand there is risk to not replacing hormones, just like there would be a risk if you had your thyroid out and you chose not to take thyroid hormone for the rest of your life. There would be risk associated with that.
Absolutely. And the timing of initiation is huge with that. So if you start the hormones early, many of those risks of hormone therapy don't exist.
Yes.
If you wait until you're more than 10 years after your last period, it's actually a little more risky to start hormones. And in some cases, you won't have that opportunity. So I often tell patients, if you want to try hormones at any time, do it now, because this is the lowest risk time and the highest benefit time for you looking forward. And then typically people stay on because they realize how much better they feel on them.
Right, exactly. And that's also to say that women who are beyond 10 years from their menopause, which is right now kind of the standard of there might be an increased risk. I don't want patients to think that if they're more than 10 years from their menopause, that it's just an absolute no, they cannot start hormone replacement therapy. What it means is they deserve a very balanced discussion of the risks and benefits of starting hormones later in life. For some women, if they have very low cardiovascular risks, there might not be a significant risk, and they absolutely can begin. For other patients, if they've developed more and more risk factors as they get older and more cardiovascular things that are worrisome, we might be a little more cautious.
Yes, totally agree.
Excellent. So any last words that you might say to patients having any kind of sexual health issues to empower them to reach out and to find the right provider so that they can have better care?
So the resources that I listed earlier, a great place to start if you're looking for a provider. Both of the organizations, Menopause Society and also I Swish, have a provider directory that you can go to and search for a provider in your state. If that's not helpful, and you have to talk to the person who is available to your primary care, who may not have as much background, bring them these websites so that they can educate themselves. We have so many resources, educational courses for clinicians so that they can learn more about this. But also just say what you need and ask for it, because the worst thing that happens is your provider doesn't know the answer, and then ask them to help you figure out who they can see to get the answer. There's also a ton of social media happening right now in terms of education that's patient friendly. People like Rachel Rubin, Jill Kraft, Samina Rahman, There's so many out there, but you want to go to someone who's affiliated with some of these major institutions so you know you're getting evidence-based information. Kelly Casperson, I can just keep going on
Oh my
forever.
gosh, yes.
Amazing people out there who are just sharing everything they can about what's going on with menopause these days.
No, I agree. And I encourage people, if they are using social media, make sure they go to that person's profile and check out their background. So even though there are tons of wonderful people out there giving out evidence-based medicine, there's also a lot of people just giving out their opinion. Look at the person you're listening to, their credentials and their training and their background, and then it will become very obvious who is a more valuable source of information and who is not.
And I would love to provide a list of sort of people I recommend on social media to you so your listeners can check that out as well.
That would be great. I will add that in the description so they have that information as well. I love it. And then my final piece would also be a lot of providers will offer a telehealth consultation, at least to start. So even if you find a provider who is difficult for you to travel to location-wise, call and ask if they'll start with a telehealth consultation. Of course, your physical exam is so important. We need to look at the quality of the tissue of the vagina and the tension in the muscles and all of those things. But at least to get started, that telehealth consultation may give you a lot of information and point you in the right direction.
Absolutely.
Excellent. Well, this has been so great talking about all of this with you today. I'm so glad you joined us, and I will put all of those links in the description so listeners can arm themselves with the best knowledge. Thank you so much.
Thank you for having me.
Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.